Yes, sir, we are
So,
mute.
yeah, a very good evening, viewers. I am Dr. Stalin on behalf of Shield Healthcare, welcoming you all for the today's session on sclerotherapy for recurrent endometriosis. So, the icons for today's conversation is Dr. Ritu Satwani, ma'am. Madam has done her MBBS, MD, FICOG, and AMR COG. Madam is the obstetrician and gynecologist, infertility specialist, sexologist, and cosmetologist. Done her ERT from Singapore. Founder and CEO of 360 Healthcare Studio, award winner and renowned medical professional who has more than 20 years of extensive experience. And Madam is the co-founder of MAM and a board member of WSCG. Now, I will also like to welcome Dr. Alini Selvaraj, ma'am. Madam has done her MD, DGO, FICOG, and diploma from reproductive medicine from Germany. Former assistant professor of OG department, Madurai Medical College, Madurai. Madam is currently the Managing Director of Madurai Ponni Fertility and Research Center and Chief Consultant Gynecologist and IVF Specialist. And Madam is practicing infertility and treatment for the past 15 years. Madam is associated with various societies like IFS, ISAR, MOX, Indian Menopause Society, PCO Society, and FOXY. Madam is editorial board member of international journals and annals of clinical case safe study. Reports University of Texas, San Antonio, Texas, USA. More than 350 presentation in both national and international journals, received various awards to her credit. With this short introduction, I welcome you, ma'am. I'm handing session to Dr. Ritu Satwani, ma'am, to take over the session for further proceedings. Welcome, ma'am.
Yeah. Thank you, Dr. Stalin, and thank you, Shield Healthcare, for providing the platform. So knowledge always increases by sharing. More that we share, more we get. So welcome everyone for this unique series, the Icons and Conversation with Dr. Ritu. So our today's icon is one of my very favorite, very dear Dr. Yajini Madam. Madam, a very, very warm welcome. Vanakkam.
Vanakkam.
So
thank you for your kind words.
I'm too glad that Madam has accepted my invitation. Mine and Madam's friendship is a long, long time back. When I think in 2013 or 2015, I'm not able to recollect exactly the year. Me and Madam met in one of the Goa conference. That is only a very short meeting. We are sitting in the one round table, and Madam is also clicking some slides presentation. I am also clicking. From there only our friendship is started. So, Madam, I'm very, very glad. And Madam is the owner of the huge Pony Test Tube Baby Center at the Madurai. And Madam is very, very active in different knowledge sharing platforms. So, Madam, a very, very warm welcome to you and warm welcome to all our dear friends who have joined all across the geography. Program is going live on the YouTube. So today, as we all are aware that endometriosis is a very, very vast problem. And so many times we treat the patient of the endometrioma and the chances of the recurrence are very, very high. Whenever we are operating or whether we are giving the GnRH analogs, always we tell the patients, yes, the chances of the recurrence are there. So today, Madam is going to share with us a very important, a new studies, what the Madam has done, especially the role of the sclerotherapy for the treatment of the recurrent endometriomas. So, Madam, now the dais is yours. Friends, first we listen to the Madam, and after that we can have a discussion, whatever the live questions we receive or whatever the questions in your mind we can have with the Madam. Yeah, thank you, Madam, once again, and a very warm welcome to you.
Thank you so much for your kind words, Ritu. Can I share my slides?
Yes, ma'am.
At the outset, I'd like to thank the organizers, the Shield Pharma, for giving us this wonderful opportunity. And I also thank my dearest friend Ritu for inviting me to this program. Let us move on to the. Yeah, I bring greetings from Ponni Hospital and Madurai Fertility Research Center. At the outset, I thank the organizers and Dr. Ritu for giving me this opportunity. Today's topic is sclerotherapy, which is a newer frontier in the management of repeated endometriomas. We all know that endometriosis is an estrogen-dependent disease, frequently resulting in substantial morbidity, severe pelvic pain, which requires multiple surgeries and also impairs the fertility. And clinically, it is defined as ectopic endometrium that lies outside the uterus, resulting in sustained inflammatory reaction. It affects the childbearing age group of women, and the exact prevalence is not known. An estimated 176 million women worldwide are affected by endometriosis. 2 to 10% of general female population estimated to be suffering from endometriosis, and 50% of infertile female do have endometriosis. In India, the prevalence is around 26 million women and 50% are infertile. There are lots of immunological factors that are significantly incorporated in the pathogenesis of endometriosis, and there is a cytokine dysregulation. And we know that the endometrial cells are able to exploit the promotion of vasculogenesis and angiogenesis mediated by inflammatory response. And there is debate going on whether to classify endometriosis as an inflammatory condition or an autoimmune disorder. This is the revised American Society of Reproductive Medicine staging of endometriosis. It comprises of 4 stages. The last one is the severe thing, which may be a frozen pelvis. And this is Enzion classification, which is a supplement to the ASRM classification. And it takes into account the retroperitoneal structures that are divided into 3 compartments, compartment A, B, and C. And the classification of the disease severity is grade 1, 2, and 3. Depending upon the invasion, if it is less than 1 centimeter, it is grade 1. If it is 2, 1 to 3, and 3, it is more than 3. And the last one is the metastasis to distant regions. This F stands for or foreign. Adenomyosis, bladder invasion, intrinsic urethral endometriosis, and bowel disease, cranial to sigmoid colon and other locations. And it resembles that of the cancer staging, like tumor, lymph node, and metastasis. There are lots of risk factors which are incorporated with endometriosis. One is the infertility, the early age of menarche, shorter menstrual cycle, heavy menstrual bleeding, nulliparity, Mullerian anomalies, and exposure to diethylstilbestrol in utero, dioxin exposure, endometriosis in the first degree relative, and prior medical or surgical therapy. It may be either asymptomatic or it may be associated with pelvic pain and or infertility. And pain related to endometriosis may present as dysmenorrhea, dysphoria, dysuria, dyschezia, low backache or abdominal discomfort, and chronic pelvic pain. The clinical features, we can find and fix a retroverted uterus or an adnexal mass, and the uterocycles may be either nodular or thickened and tender. In current clinical practice, laparoscopy is required for definitive diagnosis of endometriosis. And it takes almost 7 years to diagnose endometriosis on the whole. And positive histology confirms the diagnosis of endometriosis, whereas negative histology does not exclude it. Whether histology should be obtained if peritoneal disease alone is present is controversial. Visual inspection is usually adequate, but histological confirmation of at least one lesion is ideal. In cases of ovarian endometrioma, which is more than 4 centimeters, and in deeply infiltrating disease, histology should be obtained to identify endometriosis and to exclude rare instances of malignancy. When we look into the management, we have the conventional method, that is expectant management, medical therapy and surgery, and we have sclerotherapy. The known sclerosing agents are ethanol, tetracycline, and methotrexate. The newer sclerosing agents are leuprolide, cefabrosum, sulbactam, interferons or interleukin, and recombinant interleukin 2. For infertile patients, in case of very low AMH, we have to go for IVF with embryo transfer or oocyte donation. Now, there are lots of things in endometriosis which causes infertility, and the causes are ovulatory dysfunction resulting in abnormal folliculogenesis, anovulation, luteal phase defect, and luteinization of unruptured follicle. The immunological alterations that decreases the sperm survival, and there is altered immunity. Peritoneal factors like intraperitoneal inflammation and local production of prostaglandins and cytokines. And also the endometrial dysfunction causes interference with the implantation. Mechanical factors like anatomical distortion of tubes, altered tubal motility, and interference, they all interfere with the ovum pickup due to peritubal adhesions also there. And the coital function because of dyspareunia is also interfered. And there is sperm inactivation by the macrophages by the phagocytosis. Medical therapy is non-specific, non-curative, and aimed at alleviating symptoms till menopause or until pregnancy is desired. The rationale of medical therapy is to induce amenorrhea and create hypoestrogenic environment, theoretically inhibiting the growth and promoting temporary regression of the lesions. The side effects may be intolerable for some, and symptoms recur upon cessation of therapy. Fertility is eliminated during treatment as it suppresses the ovulation. And selection of medical therapy depends upon the therapeutic effectiveness, tolerability, drug cost, patient experience, and expected patient's compliance. The current medical therapies are hormonal contraceptives, gonadotropin releasing hormone, danazole, and non-steroidal anti-inflammatory drugs. The progestins like depamedroxyprogesterone acetate, danazole impregnated intrauterine devices, norethistierone acetate, Dynagest, retroprogesterone like dydrogesterone, and levonorgestrel impregnated IUCDs, which can be kept for 5 years, and etonogestrel implants, which can be used subdermally. The aromatase inhibitors like letrozole, anastrozole, but the disadvantages of these things are a decreased bone mineral density and also hot flashes. Selective estrogen receptor modulators like tamoxifen, raloxifene, basidoxifene can be used, and selective progesterone receptor modulators like asoprasnel and tilaprestone can be tried, and estrogen receptor ligands, alpha and beta, can be also tried. The anti-inflammatory drugs are angiogenic inhibitors like vascular endothelial growth factors and matrix metalloproteinases, and endometriotic implants grow in the ectopic locations with new blood supply. So that can be prevented by the TNP 470 derived from aspergillus, and endostatins derived from 18 collagen, dopamine agonist cabacolin in the dose of 0.5 milligram given inhibits the neuroangiogenesis. Rapamycin, doxycycline, and PPARs can all be tried. The drugs under research are immunomodulators, loxoribin and interferon alpha 2, tumor necrotizing factor alpha inhibitors, and retinoids. Pain management can be done by gabapentin and amitriptyline, and antioxidative drug like resveratrol, and future direction is targeted to genes and genomics in treating the endometriosis. The limitations of current therapy or the major limiting factor of the currently available drugs are their adverse effects and the ability of the patient to tolerate them. There is dissatisfaction existing among patients regarding the effectiveness of therapies and the impact of the drugs on the condition of their lives. Dynagest, a wonder molecule, is a synthetic oral progesterone with unique pharmacological properties and reported to display no androgenic effect, but it has a good progesterogenic effect on the uterus. It has a favorable safety and tolerability profile. The limitations of damages to our pregnancy can't be achieved during its course. It's an expensive drug for developing and underdeveloped countries because it ought to be continued for longer time, like 12 to 24 months. Excuse me. The surgical management for endometrioma is the mainstay of endometrioma is when the endometrioma is more than 5 centimeters, and laparoscopic excision of the wall of the endometrioma should be considered as the procedure of choice. Concerns have been raised as to the possibility that surgical excision may damage the ovarian reserve, but recent evidences demonstrate that part of the damage may be due to presence of the disease itself. The indication for surgical treatment should balance between the advantage and disadvantages. The advantages are satisfactory pain relief, increase in pregnancy rate, and we can get tissues to rule out unexpected malignancy or histopathology. And the disadvantages are damage of ovarian reserve and drop in AMH resulting in infertility. The limitations of surgery for endometrioma. In patients who fail to conceive spontaneously after surgery, ART is more effective than repeated surgeries. Following surgery, the ovarian reserve may be reduced as determined by AMH. In women with large endometriomas more than 5 centimeters, it ought to be removed. In women who have failed ART, further management remains controversial. And this is Endometriosis Fertility Index. It's a new validated endometriosis staging system. That is, during surgery, we just give scores depending upon the involvement of the endometriotic lesions affecting both ovaries on the left and right and other things. And we take the historical factors like age, years of infertility, and prior pregnancy status. So taking into account, we just decide whether to give her a medical management or we can straight away go for IVF and ICSI. Now let's move on to sclerotherapy. Let me have some water, please. Sorry, I have a very bad throat. What is sclerotherapy? It is often considered the treatment of choice for small varicose veins, and sclerotherapy involves injecting a solution directly into the vein. The sclerosing solution causes the vein to scar, forcing blood to reroute through healthier veins. The collapsed vein is reabsorbed into local tissue and eventually it fades. Why sclerotherapy? In the year 2016, April, a patient with a severe endometrioma who had already undergone 3 surgeries, and the last surgery was just 3 months ago. She was threatened by her husband and her in-laws to be divorced if she doesn't beget a child within a year. She and her parents were sobbing in my cabin. So the plight of this patient triggered my empathy towards her and made me search the internet for an alternative therapy for endometriosis, which can give a quick relief and resume fertility at a shorter time. Then I came across the terminology that sclerotherapy, which was practiced in US, Japan, Taiwan, and some of the European countries, and which was the method of treatment for large recurrent endometriomas. This is a novel, cheap, simple OP procedure for treating endometriomas in developing and underdeveloped countries where people can't afford much for medical management and repeated surgeries. We tried this newer modality for treating the recurrent endometriomas. So the selection criteria included women of reproductive age, those who are suffering from infertility or yet to complete their family, where there should not be any associated pathology like fibroids or other things, and suffering from recurrent endometriosis, and those who had repeated or recurrent surgeries for endometriosis. and those who belong to stage 3 and stage 4 were selected. In sclerotherapy and reaseptic precautions is the procedure. The endometriomas were manually aspirated with a needle of 17 gauge and 35 centimeters long, and using Kraft aspirator guided by transvaginal ultrasonography. An injection of leuprolide and ceftriaxone were injected after completing the aspiration without removing the needle. In case of thick and old endometriomas, aspiration was achieved using 16 gauge 35 centimeters long double lumen aspiration needle, which we use for ovum pickup after injecting normal saline and diluting the endometriomas. The antibiotic coverage dose depends upon the size of the endometriomas. And this was conducted as an outpatient procedure, and in some apprehensive patients. Earlier, we used IV sedation and mild anesthesia, but now we are not using it. These are some of the endometriomas which we have aspirated. This is this ovum aspiration needles with single lumen. The next one is the double lumen aspiration needle and the Kraft suction apparatus. This is the method by how, through ultrasound guidance, we just locate the endometriomas, and the needle is inserted in, and the endometrial fluid and the content of the cyst are aspirated. After aspiration, we just inject the sclerosing agent without removing the needle into the dead space. So this is an ongoing prospective pilot study that included 110 patients, and it was carried out in our Pune Hospital and Madurai Fertility Research Center from April 2016 till date, and it showed impressive results. This is the graphical representation of our aspirations. This is 59 not seeking fertility, 51 women were seeking fertility, ongoing treatment for 8 people, and 4 people didn't turn up for follow-up. Out of 110, 51 were infertile and 59 were Paras women. Complete resolution was observed in 106 out of 110 patients. So 96.36% was achieved a complete resolution. 4 patients didn't show up for follow-up examinations. Repeat aspiration was needed in only 8 patients out of 110. Only 1 patient underwent surgery after sclerotherapy, and out of 51 infertile, 41 conceived and delivered. 35 conceived through IVF, 5 conceived through IUI, and 1 conceived naturally. Out of 59 women not seeking fertility, treatment for fertility, 56 were married women and 3 were unmarried girls. For these unmarried girls, we did through the trans-abdominal route. 97% recurrence rate reduction, that is 57 out of 59 women, and 80.39% pregnancy outcome, 41 out of 51 infertile women was the achievement. So out of 51 infertile, 41 conceived and delivered, 40 patients conceived through ART while treating endometriosis with sclerotherapy, and 1 patient conceived naturally. This is the total number of cases, 98 out of 106, and achieved fertility for 41 out of 51 patients, that is 80.39%, and recurrence of reduction rate and pain score was seen in 96%. So the main advantage is that fertility treatment can be resumed in the same month after aspiration. The probable cellular mechanism involved in sclerotherapy of ovarian endometriomas are not fully known, but it seems that epithelial cells lining the cyst wall play an essential role when adequate contact between the sclerosing agent and the cyst wall is achieved. There is activation of the coagulation cascade and production of mediators for inflammation, causing fibrosis of epithelial lining cells, leading to cyst wall adherence. Might also enhance the cytotoxic activity of macrophages, and natural killer cells to suppress the endometrial activity. You'll see some of the references. This is a reference from Japan, where 5% tetracycline is used as sclerosing agent. The recurrence rate was 46.87% and fertility 34.37%. This is a study from Taiwan, where 95% ethanol is used as sclerosing agent. The pregnancy rate was 17.8%, and the regression of cyst was seen in 42.2%, recurrence in 58%, and because the retention time of ethanol increases the regression. If the retention is more the retention time, better the results. And these are some of the centers in the world where sclerotherapy is being done. And some of the centers are using ethanol as sclerosing agents, and some as tetracycline, 5% tetracycline as sclerosing agents. And this is a systematic review and meta-analysis by ASRM 2017, where it says sclerotherapy for ovarian endometriomas was maybe considered in symptomatic women who plan to conceive. And this was published in Fertility Sterility 2017. And this is yet another study where sclerotherapy with 5% tetracycline is a simple alternative to potential complex surgical treatment for ovarian endometriomas before in vitro fertilization, and the regression was seen in 75% of patients with a 57% of pregnancy rate. And this is about New York Fertility Institute, where Dr. Khalid Sultan and Dr. Masjid Faith, they are practicing sclerotherapy for the past 25 years as first line, and they have produced a lot of success in that. This is the treatment algorithm where the infertile women with suspected endometriosis, either they should go for a fertility workup. If they have other indications like male factor or any other tubal factor or something like that, then IVF and ICSI is done, where the next we have to look into the ovarian reserve test. If the reserve is good and the lesion is minimal with endometriosis, either we can choose a medical management or surgical treatment. If the reserve is very poor, we have to straight away go for quickly doing the IVF. In that case, we can go for sclerotherapy. If there is recurrence of endometriomas, and if the surgical after surgery also there is recurrence, in that case we can go to sclerotherapy and then followed with IVF or ICSI. If it is minimal, then we can try controlled ovarian stimulation, IUI 3 to 6 cycles. If that fails, we can go to IVF and ICSI. So to conclude, endometriosis is an ever-challenging disease affecting all age groups from adolescent to perimenopausal women. Individualization of treatment is a must according to severity of the disease, tolerability of the patient, and the desire for fertility. The standard treatment for symptomatic endometriomas, which are more than 5 centimeters, is laparoscopic surgery, and medical therapy, however, often used before surgery to reduce the size of lesion and the extent of operations. Diagnosis the wonder molecule is preferred most for patient compliance and quicker return of fertility. But the disadvantage is that fertility cannot be achieved during medical management. So now we'll move on to the advantages of sclerotherapy. It is a minimally invasive one, cheap and cost-effective OP procedure. There is less ovarian manipulation with low recurrence rate. It prevents drop of AMH and resumes fertility very quickly. And the results are quite impressive, like 92.45% success rate and 80.39% achieve fertility, 96.61% restoration of sexual health. So sclerotherapy using newer sclerosing agents prevents repeated surgeries, and it's a boon to the frustrated endometriotic patients. And this is my first patient for whom I coined this sclerotherapy. And to my great surprise, she conceived naturally during the lactation amenorrhea, the second baby also, which I delivered in 2018 October. So to conclude, sclerotherapy using newer sclerosing agents is a new frontier in the management of recurrent endometriomas. Thank you so much for your patience listening. Over to you, Ritu.
Yeah, thank you, madam. Thank you. Thank you so much for such an excellent lecture. Madam, I have one query.
Yeah.
Up to how many patients you have shown that you have tried this regimen for around 110 patients.
Yeah,
so
yeah.
is it like that any patient has got some side effects by this medication?
We have not encountered any complications during our treatment. But we had 8 patients. For 8 patients, we have to do repeated aspirations.
Okay. And ma'am,
Yeah.
what the incidence of recurrence once we, as we operate the endometrioma, sometimes the patient comes back again after a year only. That madam, you have operated the last year, now again the cyst has happened.
Yeah, for such patients only we go for this sclerotherapy. We don't want to do repeated surgeries, you know. That will damage the ovaries and
yes.
their AMH will go very low.
Yeah,
and instead of doing good to them, we are doing more harm to them.
Very true. Very
In such cases only we go for this sclerotherapy.
Yeah. Madam, one last question from my side. See, once we give this therapy, so are you doing the AMH prior to giving this therapy and after the therapy?
Usually, in my patients, the quality of egg is better after this therapy. Though the retrieved oocytes will not be good in number, but they are good in their quality.
Okay. Madam, but routinely, are you doing the AMH? Because once we are...
Yeah. To decide the sclerotherapy, we do the AMH. When it is very low only, we go for sclerotherapy.
Okay. Thank you, madam. Thank you so much. Yeah. Thank you so much.
Thank you so much.
Madam, I want to ask one question.
Yeah.
Have you tried any other sclerosing agent or the same combination used?
Yeah. Now, off late, we are using methotrexate for those for not seeking fertility.
Okay. And only methotrexate or anything else?
And metrogel also, metronidazole.
Okay.
Metronidazole for those who are coming for recurrent endometriomas. Even after this sclerotherapy, we are now trying methotrexate for those who are not seeking fertility, and metronidazole for those who are seeking fertility.
Madam,
okay. And what is the post-operative prescription? That is anti-inflammatory or like that?
Yeah. We do it under antibiotic coverage, and we give the patients antibiotics for 3 or 4 days following this
procedure. Any anti-inflammatory or like that?
Yeah, with chimeral fort and other things also. We give anti-inflammatory drugs also.
And Dynogest post-operatively, will you continue?
Those who are seeking fertility, we go straight away for IVF stimulation protocols. And those who are not seeking fertility, we put them on Dynogest, Gabergolin, so many things.
Thank you, madam. Nice lecture.
The herbal endotone, we also put them on endotone.
Okay. Thank you, madam. Nice lecture.
Thank you for the series.
The voice is not clear.
My voice is not clear?
Yours is clear. Somebody is asking.
Madam, I want to know in the patients whom you are giving the methotrexate, in that patient, usually the deficiency of this folic. So you are giving some supplements for that also along with this methotrexate?
Yeah. We give folic acid also along with that.
Okay. So madam, in this is methotrexate is giving the good results, or metronidazole, any comparative study have you done in some patients?
Yeah, now we are doing it. And I have to come with the results later. Maybe it's an ongoing thing. And because of the corona, we could do it properly for the past 2 years, but now we have started it. And methotrexate, I'm doing it for those who are not seeking fertility.
Madam, yesterday I am presenting a paper. I presented a paper in this one conference of the Arab Society. So there one doctor has shown some studies regarding the use of the ethanol for the treatment of the recurrent endometriomas. So have you experienced or any studies related to that?
Because when I was going through the complications of ethanol, it was very severe, I think.
Yeah,
there was alcohol intoxications, abscess formation, and so many things. So I never tried it. I never tried it.
Okay. Thank you so much, madam. Thank you from the bottom of my heart for accepting my invitation. Thank you, madam.
Thank you so much, Ritu, for giving me this opportunity. Thank you. And I thank the Shield Farm also for giving me this wonderful platform. Thank you so much.
Can you please help me to check from the YouTube? Is there any questions for this session?
Yes, ma'am. There are 3 questions, ma'am, on the Shield Connect page. So first question is, how to prevent recurrent endometriomas? Any special surgical technique or energy sources to be used to prevent this?
Of course, the first surgery should be meticulous, so that they need not go for recurrent things. So it should be done by highly expert people, and the energy source, of course, with less intensity should be used. That is my experience.
Yeah, ma'am. Thank you, ma'am. And we have one more question, ma'am. Whether what is the precaution to be taken while aspirating ovarian endometrioma? Any chances of ovarian abscess in your experience, ma'am, after the procedure?
Yeah, I have never come across any abscess during my 110 aspirations. And we just do the vaginal toileting, and everything is done under strict aseptic precautions. And it is done in the theater under ultrasound guidance. And only a single prick, we enter into the endometriomas. After completing one, if you have multiple endometriomas, complete one, then you have to puncture the next one. And only one puncture through the vagina. Through each, just like doing an ovum pickup, we proceed with the things. Okay.
Yeah, ma'am. Ma'am, one more question, ma'am. What type of anesthesia you prefer for this procedure, ma'am?
To start with, we were giving IV sedations, but now we just oral anesthesia. There's nothing else. Patients are well tolerating it because they are suffering from lots of pain of endometriotic lesions. They have lots of sleepless nights. Some of my patients have been divorced because of severe dyspareunia. And for such people, this pain is nothing. As we were aspirating, they will just snore and they'll go for sleep because they are relieved of the tension and the pain.
Yeah, ma'am. Thank you for addressing all those queries, ma'am. We don't have any other questions in the chat box, ma'am.
Thank you so much for
Thank you, ma'am. Thank you for another wonderful session, ma'am. Thank you for spending your valuable time with us today, ma'am. And thank you, Ritu Satwani, ma'am, for being with us today, and the other audience who have joined through this link. And I also like to thank the participants for their active participation, ma'am. Thank you, ma'am, and looking for many more webinars in future too, ma'am.
Yeah, thank you so much. Thank you so much.
Thank you. So we
Bye.
hope to see you soon in person, ma'am.
Yeah. Bye.
Bye. Thank you, madam. Thank you.
Yeah, ma'am. Good night, ma'am. Good night.
Good night.
Thank you, Dr. Stalin.
Yeah, ma'am. Bye, ma'am.
Yeah, bye-bye.